Hello and welcome. We're delighted to have you here at today's IAS webinar. We'll be talking about the diagnosis and management of non-Kaposi sarcoma dermatologic conditions in people with HIV. And as a small reminder, you might be wondering, why are we talking about non-Kaposi sarcoma dermatologic conditions? And that's because Dr. Maurer, who's joining us as our speaker today, gave a webinar this time last year on Kaposi sarcoma specifically. So we definitely encourage you to check that out in the IAS vaults to look for all the latest and greatest on Kaposi sarcoma. And I'm sorry, it's IAS-USA. I've already made an error in terms of our introduction, so I apologize. So welcome to IAS-USA. And so you can definitely take a look um, in that archives for the Kaposi sarcoma talk from last year. With that, I will briefly introduce myself as people start to come in. I'm moderating today's presentation. My name is Dr. Esther Freeman. I'm Director of Global Health Dermatology at Massachusetts General Hospital, Harvard Medical School, and I work in infectious disease epidemiology, particularly at the intersection of HIV and dermatology. And a lot of my research work is in sub-Saharan Africa, particularly in East Africa with Dr. Maurer. We are so delighted to have Dr. Maurer with us today, and I'm going to go through some intro background slides in the presentation, and I'll do Dr. Maurer's bio in a moment. So this is to remind, I got us ahead of myself. This is to remind everyone of last year's on-demand webinar that's still available, which was the focus on Kaposi sarcoma in people with HIV. So definitely take a look at that archived on-demand webinar, as it has a lot of direct information about Kaposi sarcoma. And for that reason, we won't be focusing on KS today. We'll be talking about everything else, skin and HIV. Next slide. So just to share the relationships with ineligible companies from the web board, which you can see here. Next slide. And in terms of financial relationships for our presenter, Dr. Maurer and myself have both received consulting and advising fees from L'Oreal Dermatologic Beauty. Next slide. So there are continuing education credits for today. IAS-USA is accredited for continuing medical education. The IAS-USA designates this live activity for a maximum of 1.25 AMA category credits. And just to remind you, here are the different types of credits, for example, for CME, nursing contact hours, etc. Next slide. In terms of grant support, we're really appreciative of this part of IAS-USA national educational effort funded through commercial companies, and the platinum supporters include Gilead, Merck, Viv Healthcare, with additional support from Hologic Inc. So we are going to have some polls today. These will be poll questions that should pop up for you in a separate window that will still show the poll question. You'll choose your response for the poll, and then responses will be displayed after that poll closes. So there'll be a little bit of a delay. If you have questions, we'll remind you to please use the Q&A button rather than the chat feature. So specifically, this will be in the Q&A button, and we'll do our best to answer as many questions as we possibly can in the Q&A at the end of this session. But we would appreciate if you could use your full name and your institution, and particularly institution is important and required. And the chat is now open. You'll see a chat from one of our moderators here. And so please don't submit questions to the chat, because we will only see the questions that are in the Q&A. Thank you. So with that, I would like to welcome Dr. Maurer back to an IAS-USA webinar. Dr. Maurer is a good friend of mine and someone I was lucky enough to train with over many years. She is board certified in two things, both family medicine and dermatology, with 2 HIV fellowships, both in family medicine and dermatology. She founded the HIV Dermatology Clinic in San Francisco General Hospital, really at the height of the HIV epidemic, and was chief of derm at San Francisco General for 25 years. She retired from SF General and from UCSF to work with AMPATH, which is the academic model for HIV care through Indiana University, in order to head the global dermatology program, continue her research on HIV and Kaposi sarcoma dermatology with our team in East Africa. And she's also turned her attention to starting a nonprofit organization called I always say I have a hard time with this, Toby. I'm going to try one more time. Dermatocracy. Did I get it?
That's it.
Dermatocracy. Okay, I just had to wind myself up. Dermatocracy, which is a really cool organization to democratize dermatology and place much needed dermatologic services in the areas of the world where they are not. And that includes things like teledermatology. And so, without further ado, I'm so honored to present my friend and colleague and certainly inspiring mentor, Dr. Maurer, to all of you.
Well, thank you so much, Esther. It is always a pleasure to be with you and work with you. As you said, we are good friends and colleagues and continue the fight. So thank you for hosting this, and my thanks also to IAS-USA for always supporting our work and for supporting this webinar today. Let me try to make sure I'm sharing correctly. There we go. All right. So, without further ado, it's really an honor to speak with all of you today about the various HIV conditions that we have and that we have seen. Let's see if I can advance this. All right, here we go. You can see what you are seeing what
We're
we
currently
need right
still
now.
seeing the intro slide there, Dr. Maurer.
Okay. Mhm. Okay, there we go.
Yes, now we are seeing your next slide.
Okay. So, learning objectives. After attending this presentation, learners will be able to describe the features of common and clinically significant derm conditions in people with HIV, PWH, as we will refer to that, other than Kaposi sarcoma. Utilize evidence-based diagnostic and management strategies for derm conditions in PWH, including treatment considerations related to immune status and antiretroviral therapy regimens, and integrate patient-centered approaches to improve outcomes. So, pre-test question 1. A patient presents to care with widespread scaly tinea that has not responded to a 3-week course of oral terbinafine. Which of the following is the most appropriate next step? A, extend treatment course to 12 weeks. B, switch to oral ketoconazole immediately. C, send a specimen for fungal culture for suspected T. mentagrophytes genotype 7 infection. Or D, initiate clobetasol ointment twice daily as the patient has eczema. And looks like most of our respondents are going with C. All right. Our next question, is that coming up? Yep, there we go. Great. So a patient presents to care with a painful inflamed nodule in the suprapubic area. Which of the following diagnoses is least likely? And this is a single choice. A, verrucous herpes simplex virus, HSV. B, Mpox. C, trichophyton mentagrophytes genotype 7. Or D, varicella zoster virus. And it looks like most of our participants are choosing D, varicella zoster virus. All right, we'll advance and we'll get back to those questions after the presentation.
You can go ahead and advance your slides, Dr. Maurer.
Okay, thank you. So the focus areas that we want to look at is number one, who is coming in with new HIV diagnoses? And by that, I mean, what skin conditions prompt HIV testing? And what vaccines and prophylactic antibiotics should you think about? The second focus area is I want to look at old problems that never go away and what can we do about them? And as Esther said at the beginning of this webinar, for a deep dive with regard to Kaposi sarcoma, please see previous IAS-USA webinar on Kaposi sarcoma. So prompts for testing. What we want to look at, and what I'll be discussing is unusually shaped tinea, facial molluscum, HSV in all the wrong places, zoster under the age of 50, Kaposi sarcoma, mpox, syphilis, and skin picking in meth use. These are all areas that one should consider testing for HIV. So let me start with tinea, which you can see so beautifully demonstrated in both these slides. On the left, we see a very wide area of tinea characterized by this very serpiginous border, but well demarcated border. We always tend to think of tinea with central clearing. You don't see so much central clearing in this slide. However, on the facial slide here on the right, we do in fact see a nice demarcated border, this time with central clearing. This is highly unusual, again, to see such big areas of tinea and on the face. Think about HIV in those circumstances. And again, here we see a beautiful example of tinea, again with this well demarcated border here, and this time some very nice central clearing that we all talk about but don't hang our hats on. So treatment for widespread tinea. You want an HIV test if you suspect anything here and look for risk factors for HIV. The treatment, the standard treatment is terbinafine, 250 milligrams daily for a month. However, please be informed that there are no established guidelines for treatment right now because we are seeing a lot of resistance to our antifungals, especially reported from areas around India, Pakistan, Nepal, and now Mexico. I want to also alert you to this new type of tinea that we are seeing, and this is that TM7 or tinea mentagrophytes, trichophyton mentagrophytes. And you can see here that this presents a little bit differently than the tinea we have just mentioned, in that we see these nodules that are in the suprapubic area, very painful and red. We don't see the ringworm that we usually consider to be tinea. We don't see scaly areas. Also, we can see this type of tinea presenting as really pustules and nodules around the mouth area on the chin, and you can see above the upper lip here as well. These tend to crust up with time. So emerging trichophyton mentagrophytes, we see in MSM, including persons living with HIV. Again, purulent, highly inflamed subcutaneous lesions. The ring lesions are absent. If you're trying to diagnose this, you want to pluck the hairs or do a tissue culture and send that to the CDC for speciation. Treatment includes terbinafine or itraconazole for at least 4 to 12 weeks duration. Again, there's a tendency now to treat trichophyton and Altenia a little bit longer than we had originally thought of. Again, usually 4 to 12 weeks duration. I mentioned HSV in all the right places and wrong places as being an indicator for HIV testing. And here you can see HSV in all the right places, and that is particularly in the perianal area. I always say to my trainees that if a patient presents with a painful ulcer or erosion in the perianal area, that is HSV until proven otherwise. Also on this picture, you can see that there is a linear lesion here. Again, a linear erosion, painful. This is HSV. But HSV and HIV can present in other places as well. And this too is HSV on the finger. Please note it's an erosion, it's very painful. Up here on the right is also an HSV lesion in a person living with HIV. This time characterized by a serpiginous border and an ulcer. You will note that this patient has an amputation of a finger, and that is because this patient presented with a painful area that everybody tried to treat with IV antibiotics, treating this for staph and any other possible infection. And the pain was so bad that the patient begged for an amputation, which she got on the surgical ward. And then she developed this erosion. Thankfully, for some nurses who were on the ward, she was actually scheduled to get another amputation of a finger, and they asked that derm come on in. This was, of course, HSV and not some occult weird bacterial infection. And with acyclovir at the time, 5 times a day, 200 milligrams, she was cured within a few days. So again, don't forget HSV presenting and sometimes mimicking bacterial infections, but presenting on other parts of the body besides the genital area. And this too is HSV, again, characterized by that serpiginous border with a central ulceration. And this too is HSV, again, presenting in an odd place, very wide, HSV on the lower lip. Again, should indicate that HIV and HSV are playing a role together here. And I'm sure you would all agree, this looks like a staph impetiginized infection, but it is not resolving with your typical antibiotics. Why is that? Because this is HSV, once again, mimicking Staph aureus in this case. So HSV for acute episodes, we are treating with acyclovir 800 milligrams 3 times a day for 3 days, or valacyclovir 1 gram twice a day for 3 days. I will refer you to the STI treatment guidelines from the CDC that go back to 2021. But the key here is that in modern day, we are actually not prophylaxing for recurrent outbreaks in people with HIV. And that is because we do not want to select out mutations with long-term prophylaxis. And what does long-term prophylaxis do if we do select out mutations? We're starting to see something called herpes vegetans, which you can see here is characterized by this nodule that looks very vegetative or verrucous on its surface. Similarly, we can see herpes here on the penis, again with this vegetans or verrucous looking surface. When I first saw the patient who presented with the image on the left, I thought that this patient may have had squamous cell carcinoma, biopsied this patient, and the lab said, no, this is herpes simplex. It looked like herpes under the microscope. I ran down to the lab thinking that they possibly mixed up specimens, only to discover that this is herpes vegetans, again, really mimicking tumors that look like almost squamous cell carcinoma clinically. But again, this is herpes vegetans. This is usually a cyclovir resistant, and this is emerging as a problem worldwide. We think, again, it's because we have these suppressive doses of acyclovir, which have been used in recurrent HSV infection, and we are actually selecting out these resistant strains. How do you treat this? Well, with topical or injectable cidovovir. And let me bring your attention to pratelivir, which is a novel oral helicase primase inhibitor active against HSV-resistant, both HSV-1 and HSV-2 in persons living with HIV. We have seen some good results with this drug, 70% healing with this drug compared to 30% healing on foscarnet. And this was presented most recently at CROI, and this drug is now in phase 3 clinical trials. And here's a patient who presented again with this tumor-like lesion, which turned out to be acyclovir-resistant HSV. We injected this area with cidovovir, and within a few weeks, we saw this flattening and really resolution of that acyclovir-resistant HSV. Well, this very disappointed looking woman, because she's been waiting for hours, presents with these blisters, as you can see over here, on a red base. And this is, of course, herpes zoster or varicella zoster. We also have seen what we call immune reconstitution zoster. And these are patients who present, again, with these vesicles in a monomorphic state, as you can see here, usually on one dermatome. This is a patient who I wrongly accused of not taking his medications. He swore that indeed he was suddenly compliant and adherent to his HIV meds. And indeed, he got this immune reconstitution herpes zoster. What we want to say about herpes zoster is that if you see herpes zoster in anyone under the age of 45, you are really obligated to HIV test that patient, as we know that zoster can present in HIV as a presenting sign under the age of 45. In people with HIV over the age of 19, they should indeed get a zoster vaccine. The dose is 2 doses of Shingrix, and this will be very protective with regard to getting herpes zoster, which can present with pain and erosions as well. And so great if we can prevent it. Now, I promised not to do a deep dive into Kaposi sarcoma, but we are still seeing Kaposi sarcoma presenting as a new presentation of HIV, particularly as we see decreased resources in our communities and in our healthcare system, not only in the United States, but around the world. New presentations of Kaposi sarcoma will look like this. They will present with these purple lesions, not much to speak of, but again, they're sort of oval in shape. And again, you can see over here in a darker skinned patient, this darker purple area, not so noticeable, not painful. Patients or providers may completely ignore this as just being a little reddish purple area that will hopefully go away. Please be alerted that this is Kaposi sarcoma in its earliest stages. So, if a patient comes in with these purple-looking lesions, certainly check for HIV status, but please remember that not all persons who have Kaposi sarcoma will be HIV infected. We are, in fact, seeing HIV negative gay men in large metropolitan areas who are HIV negative but presenting with these purple lesions. However, if your patient does have HIV infection, look for systemic symptoms. You want to ask them about hemoptysis and melena and look for lymphedema. If the answer is yes to any of these, you are obligated to start chemotherapy and monitor those patients. If the patient is HIV infected but has none of these systemic symptoms, you can certainly go forward, start your antiretrovirals in this patient, and wait for resolution of these KS lesions, which sometimes take anywhere between 9 and 18 months. In our HIV negative gay men group who have Kaposi sarcoma, I say, please feel free to give us a call. We don't have that many remedies. Again, these are patients who are not HIV infected. So in those patients, we will inject local chemotherapy. We're starting CCR5 blockers in those patients and injecting local PD-1 inhibitors like nivolumab. Moving on to patients who present with now what we are seeing as these painful papules in the perianal area, also red and painful papules, as you can see here on this person's chest. Here's a closer up image on the right. You really see a red base with what almost looks like a papule or almost looks like a mollusca lesion here. This is, of course, Mpox, which there is always a low level of Mpox in our communities, and we have seen recent outbreaks of Mpox throughout these last few years. Again, in this picture, you can see the typical papules of Mpox, but what you also see in this picture is an erosion. So these can grow and become erosive and can be very painful. As I said, Mpox always exists in our environment at low levels. The way to prevent Mpox is to give 2 doses of the vaccine, dose 1 4 weeks and dose 2 2 weeks later. That will give maximum protection against Mpox. If you are trying to diagnose Mpox, you can certainly get PCR from the health departments in your local region. If you are seeing anyone who presents with Mpox, please HIV test your patient. And again, there are guidelines from the CDC that date back to December 2025 that are excellent for both diagnostics and treatment suggestions. And again, we are seeing these erosive lesions, and I want to bring that to your attention because some of these patients have not only Mpox, but they have concomitant syphilis. And we are mostly seeing these erosions, these deep erosions in patients who have both Mpox and syphilis, like we are seeing in this image here. So, erosive lesions in Mpox. Test and treat concomitant Mpox, HIV, and syphilis, if that is relevant. For Mpox that is not severe, supportive care is the treatment and pain control. Remember, I said that these are often very painful. What about TPOXX? Well, there is not enough evidence to show that it promotes healing compared to placebo, so we are not pushing for TPOXX treatment anymore, but rather supportive care. If your patient has severe mpox, that is widely distributed mpox, or mpox with syphilis, that is erosive, we are recommending that the mpox be treated with the following medications: cidovivir, or IV vaccinia IgG, which you can get through the CDC. Pro tip that I like to talk about is if your patient does in fact have an erosive lesion, topical cidovivir has been helpful to control the scarring in those erosive lesions. That can be formulated at your local pharmacy. It's not inexpensive, but they will take the IV cidovivir powder and put that into a cream, formulating it as a topical application, and that does in fact seem to control the scarring. So moving on, I mentioned syphilis. I would be remiss not to talk about syphilis that really we see so often in our patients with HIV. Obviously, if you're seeing syphilis, you should HIV test your patients. And here you see what we call the ham-colored lesions, so characteristic of syphilis. And this is really what syphilis presents most frequently to me as looking like almost a drug rash. These maculopapular lesions. You look at this patient and you want to ask, does that itch for you at all? And the patient will say, no, doesn't itch. No, not at all. You look for a relevant antibiotic history, nothing. Don't forget that this could be syphilis, and it is worth testing. Patients with syphilis need to be tested for HIV. Be on the alert for syphilis in persons living with HIV, please. Treatment for cutaneous syphilis is still benzathine penicillin or doxycycline for penallergic patients. And of course, post-exposure prophylaxis for syphilis includes doxycycline, 200 milligrams within 24 hours of condomless sex. This has eventuated in a rate reduction of syphilis by 87% in persons living with HIV. So again, doxycycline has really made a huge difference as in post-exposure prophylaxis for syphilis. But syphilis is the great mimicker, and I confess to all of you that I miss syphilis, just like the next guy, even though it's always at the back of my mind. And this is a patient who presented to me around the time of COVID with almost an urticarial look. I treated this patient with every antihistamine known to mankind, and no change, no change. And it almost started to look infiltrative in this patient. And I thought, perhaps this patient has a type of cutaneous lymphoma. Biopsied him only to reveal that this is a presentation of syphilis. And this too is a patient that I missed with regard to syphilis. This patient has intense scale of his hands. And again, of course, I treated him for hand eczema with every topical, with every oral steroid, trying to reduce this palmar scale. Finally, I biopsied him again, only to reveal that this is syphilis. So syphilis does, in fact, present in many different ways. If your patient is not responding to what you think is a standard treatment for eczema or urticaria, or perhaps has a cutaneous lymphoma, please biopsy the patient. You might be surprised to see that this is actually syphilis. I do want to spend a minute talking about meth use, in that we're seeing a lot of meth use in our patients, both in the HIV infected population and the HIV negative population. But this eventuates in a lot of skin picking. Patients feel compelled to pick their skin, not that it itches so much as they feel that there's something crawling and they have to get it out. When I see a lot of this skin picking, I really do think about meth use, and I do HIV test our patients. How do you treat this? Well, not well. I can tell you that I don't have great treatments for getting patients off meth. And the sad situation is, even if you can get your patient off meth, they will continue to have the sensation that makes them want to pick their skin for about 18 months. So we really don't have treatment. Uh, Patients will often come in asking for oral antibiotics because they think that their skin is infected. It is not, it's just picked. Word on the street is that you can get topical erythromycin to put on these areas so that they don't become super infected. And I am perfectly fine with giving topical erythromycin for this. Uh, Please don't keep giving your patients rounds and rounds of oral antibiotics. Again, these are not infected areas. I want to go on to warts, squamous cell cancer, and common diseases like acne, psoriasis, and eczema, because these are the diagnoses that persist even in the face of good viral control in our HIV-infected population. So, human papillomavirus, still a burden on cutaneous skin and genital skin. They are, for me, the bane of my existence because we are not brilliant at treating HPV. On the genital types, HPV, we do have a vaccine in persons living with HIV, and we advocate for getting that vaccine to our patients who are age 26 and under. Otherwise, we're sort of left with local destructive techniques, which include liquid nitrogen and podophlin under occlusion. That's a combination that I like to use in genital HPV. I will hit the area with liquid nitrogen twice and then apply podophlin. We have also used cidovovir injections for HPV. That's not going away, but I will tell you again that cidovovir is very expensive. These formulations for either injections or topical use are in the hundreds of dollars, if not thousands of dollars now. And if there is a wart that is just not responding to your treatments and seems to be getting bigger or more eroded, you do want to biopsy that patient to rule out squamous cell carcinoma. And here's a typical wart. Please note that this is a linear wart. And why is that? There is a phenomenon in warts called the Kebner phenomenon, so that warts tend to go where there's traumatized skin, which sometimes goes into a scratch mark, like you can see in this patient presenting with a linear verrucous lesion. This is a typical wart. And again, you can see on these fingers multiple typical warts, part of what we see in HIV and non-HIV infected populations. So multiple treatments. Sadly, all of our treatments are about 50% effective. Again, liquid nitrogen is used often for cutaneous HPV. Liquid nitrogen in combination with podophlin can be used. We are also injecting Candida into the warts. And here you need an intact immune system. That is, your patient must have a viral load that is stable and viral load under 50. Candida works by injecting into a wart and stimulating the immune system to eat the wart. It really doesn't matter what you do for wart treatment, 50% efficacy, as I mentioned, but whatever you decide to do, the only evidence that is around shows that you've got to do it at least every 3 weeks, and usually for about 12 sessions before you'll get resolution of a wart. For genital warts, we are using imiquimod, which is a topical application. Patients should use it in the genital area, not every day, but every other day for about a period of 12 weeks. See them in 16 weeks, and then treat any recalcitrant warts with liquid nitrogen or, as I mentioned, liquid nitrogen with podophyllin. The HPV vaccine, really 2 treatments, but before age 25 or 26 and under is really the recommendation. Now, here's a patient who presented with a wart. This wart, though, started to become erosive, as you can see here, and in my mind, made the transformation to squamous cell carcinoma, which we know HPV can do that. When we biopsied this was, in fact, squamous cell carcinoma. And this is a patient who presents with these eroded lesions in the perianal area, referred to me for treatment for warts. But I hope you will all take this seriously to say, this looks a little more extensive than you should see in just warts. And the erosion is not right. Of course, we biopsied, and in this patient, we biopsied in 4 sample areas. And of course, this was squamous cell carcinoma. Well, this is a patient who also presented to me with what seemed like a wart in the on the oral mucosa, and he was just not getting better, even after my multiple sessions of liquid nitrogen. And he insisted that I biopsy him, and I thought, oh, I'm just going to try to satisfy his whims, only to find out again that this had already made the transformation from HPV to squamous cell carcinoma. Patient was right. Got to listen to your patients. And of course, this is a squamous cell carcinoma in one of our HIV-infected patients, a sad situation in that his CD4 count was about 500 when he died of squamous cell carcinoma. We do know that squamous cell carcinomas do metastasize, and that is what killed this patient, even though he had good control of his HIV virus. And this too is a patient who died of his metastatic squamous cell carcinoma, again with good CD4 counts. So please be on the lookout for squamous cell carcinoma, which usually does not present with this look, but this is a secondary squamous cell carcinoma that happened in this patient. So lots of recurrence rate. There's a high recurrence rate of squamous cell carcinoma in persons with HIV infection. So be on the lookout. Have a low threshold for biopsying anything that is not healing or that looks eroded. And again, metastatic squamous cell really arises from what we call the high-risk areas of squamous cell carcinoma. Mainly if a squamous cell carcinoma presents in the temple area or on the mucosa around the lips or on the lips, that's high risk for metastatic squamous cell carcinoma. And we see thousands of deaths a year from metastatic squamous cell carcinoma. Well, what about psoriasis? If you watch television, you might be lured into thinking that everybody has psoriasis. They're certainly advertising many psoriasis biologics on television. In fact, only about 5% of the population has psoriasis, and we also see psoriasis in our HIV-infected patients. However, I must say that psoriasis in our HIV-infected patients treated with antiretrovirals seems very easy to manage once HIV virus is under control. But you might see a patient who presents with these lesions here, as you can see, these silver scale lesions. What we see in psoriasis is these silver scaled lesions that are bilateral and symmetric. You're not seeing silver scale here. You're seeing more of these purple lesions under the arms because these are moist areas. So you won't see that thick silver scale. But if you look elsewhere on the body, like on the back, this patient would have these silver scales as I'm showing you here. So again, only 5% of the general population has psoriasis. We have known for decades that if you can control HIV virus with antiretrovirals, then you don't need much more than triamcinolone 0.1% ointment twice daily for any new or small lesions or recalcitrant lesions. Is there a need to go for all these biologics that are mentioned on television? Probably not in our HIV-infected population because their immune systems are really being controlled by the antiretrovirals. I have never had to go to a biologic for psoriasis in an HIV-infected patient, but if you feel so compelled or your patient demands it, which we are seeing a lot of that now, make sure that your patient does not have active Hep C. That is a contraindication to using biologics. What about eczema? Well, unfortunately, eczema is one of those things that does not get better with viral control. And here you see a patient who's got eczema characterized by thickened skin that is very itchy. And usually the demarcation is not what you would see, like you would see in tinea, for example. Our eczema treatment is topical steroids still. That's our first line. But again, if you watch TV, you'll see that this biologic dupilumab or Dupixent is being advertised for use in the treatment of eczema and even what we call prurigo nodules, which you can see in this patient. He has some nodules, but he actually has thickened lichenified skin from just rubbing and scratching his skin like crazy. And we now know that Dupixent is one of the great safe and effective treatments for this type of skin condition, prurigo nodularis or lichen simplex chronicus. Well, again, I do want to talk about steroid use. Now we're looking at testosterone use, eventuating in bad acne. Now, I did not go into dermatology to treat acne, but we are seeing acne showing up in a lot of our patients, particularly those who are using anabolic steroids to pump themselves up and become more buff, and even testosterone. And this type of acne really presents on the chest, but most prominently on the shoulders. If you see acne on the shoulders, ask your patients about anabolic steroid use or testosterone use. Growth hormone can also present with this type of acne primarily on the shoulders. For the nodulocystic acne that we are seeing, please don't think that you can get away with using topicals or benzoyl peroxide for that. You really have to go with oral medications, something like doxycycline, which we give 100 milligrams twice daily for 2 months. Try to get your patients off anabolic steroids. If they need testosterone, well, you're sort of stuck. These are patients who may need long-term use of doxycycline to keep their cystic acne under control. But this type of cystic acne, particularly on the shoulders, is very hard to treat acne, sometimes does not respond to doxycycline. Our Brazilian colleagues have taught us that these are patients who might do quite well on azithromycin. I would recommend that you send such patients who are difficult to treat to dermatology. Again, we experiment with various oral antibiotics, and azithromycin being one of those. So with that, let me end. But what I want to do is go back to our questions that we asked, and let's see how you might answer these questions now. Again, we're going back to our patient who presented with widespread scaly tinea that has not responded to a 3-week course of oral terbinafine. Which of the following is the most appropriate next step? And again, extend terbinafine treatment course to 12 weeks, switch to oral ketoconazole immediately, send a specimen for fungal culture for suspected TM7, genotype 7, or initiate clobetasol twice daily as the patient most likely has eczema. And all right. So here we are seeing persons, most of our respondents, again, selecting C, send a specimen for fungal culture for TM7. Few are going with A, extend terbinafine treatment course to 12 weeks. Let us go to the right answer here. Let's see. Do we have a slide for that?
I think you'll have to advance to the next slide to see the explanation.
Okay. There we go. The actual correct answer here is A. So given current trends in tinea infections, this patient likely has tinea that requires a longer treatment duration. As I had said, we are now understanding that we've got to treat tinea for longer periods of time. We are definitely seeing resistance to our treatments, but our first way of treating tinea is to really treat with standard treatments like terbinafine, but extend the duration of time. Oral ketoconazole should never be used. In fact, it's pretty much off the market because it causes transaminase elevation. TM7, good of all of you to think about TM7 because this is a new type of tinea that is presenting. But in this question, the trick was that the patient presented with a widespread scaly rash rather than the inflammatory nodules so often seen with TM7. When you see a widespread scaly rash, that's normal tinea, but requires a longer period of treatment in the modern era. And clobetasol, you sure don't want to treat a patient with clobetasol who has tinea because that will just exacerbate tinea and is not the treatment for tinea. Post-test question 2, a patient presents to care with a painful inflamed nodule in the suprapubic area, which of the following diagnoses is least likely? A, verrucous herpes simplex, B, mpox, C, trichophyton-Montag genotype 7, or D, varicella zoster. Give you a minute to answer that, please. All right. So it looks like most participants have chosen D, varicella zoster, as being the least likely to present with an inflamed nodule. Okay. See if I can advance. There we go. And you are, in fact, right, those of you who chose D. Varicella zoster virus is a blistering disease and does not usually present as a nodular disease. You are all correct. The other possibilities, of course, mpox can present as a nodule. The point here also about the new tinea, TM7, often presents as a nodule. And of course, herpes vegetans, that is acyclovir-resistant herpes, often presents as a nodule as well. So good on you. That was the correct answer, D. So with that, I think that will conclude the lecture part of this webinar, and very happy to proceed on to the Q&A session. And please feel free to ask the questions. I know that Esther has been monitoring for some of those questions. Thank you all. Esther, back to you.
Great. Thank you so much, Dr. Maurer. And no matter how much time I spend with these topics, I'm always learning something new every single time I listen to you. So really appreciate that. While people are gathering their questions, please feel free to put that in the Q&A. And Dr. Maurer, you can actually stop sharing your slides if you wish. And so we'll have you put that in the Q&A. If it's the Q&A button happens not to be directly in the bottom of your screen, which it may or may not be, you can always hit the More button, and then the Q&A button will appear. And actually, just a quick comment, and then we'll move on to questions. I think we did put in the chat for people some resources from the American Academy of Dermatology. We have an emerging diseases task force, which I've chaired for the last couple of years, that has put together resource centers that are free. You don't have to be a member of the American Academy of Dermatology, and they're freely available. And those resources are available in the links in the chat. And in particular, since Dr. Maurer was talking about T-Mantag type 7, we actually have a whole section just dedicated to T-Mantag type 7, and that's continually updated with the CDC. The fungal CDC disease branch works directly with us to make sure that that information is readily available. And so for those of you who know Jeremy Gold at the CDC, who's one of the main fungal disease folks over there, is continually working with us to keep that information on T-Mantag as updated as possible. So if you ever have a question or a doubt about T-Mantag, it can be a great resource that is constantly updated for you. So I just wanted to give a little shout out to that resource in relation to Dr. Maurer's comments. I did see the first question in the chat was about HPV, Dr. Maurer, and it was specifically about the recommendations to use the HPV vaccine up to 45 years of age.
You can the efficacy that we understand is best at 26 and under. People are pushing now for over 26, but we think that it's actually too late after age 26 to make a difference. So you might be getting a couple of HPV types that the patient hasn't seen but most people will have seen the HPV types by age 26 that we're aiming to target.
And the next questions that actually came up twice was two different comments about the age up to 45. Next question was about coming in wanting to confirm that people with HIV should not be on standard prophylaxis for HSV.
Yeah, so there isn't a lot written about this. I made reference in the slides to a good paper on this, but we are continuously concerned about this. And firstly, I will say that we're not seeing that much recurrent HSV as we did in the olden days when people's immune systems were not well controlled. So the great news is that recurrent HSV is something that seems better under control because of our antiretroviral therapy. But again, if you do have a patient who is reporting more than 2 or 3 recurrent outbreaks per year, those are the types that in the past you would have put on prophylaxis or on suppressive doses of HSV. And again, that's where we bring up the great concern that we are actually selecting out for mutations. You can certainly warn those patients that the minute they feel any tingling at all, or any sensation where they get their recurrent outbreak, that they can start the acyclovir quickly. And again, I listed the doses for acyclovir and valacyclovir really for about 3 days, and that should take care of the outbreak.
We next have a series of questions around tinea. So I'll kind of do these as a group, and I'll offer also one little comment myself. The first comment comes in and says, I have seen multiple ringworm-like lesions from T-Mentag type 7 online, including at the CDC website. You say not. And I will let you respond, but I will say, in my experience, and I would definitely encourage every of you to take a look at the T-Mentag. If you click through the tinea website I put in the chat from the AAD, you'll actually see some example images on the American Academy of Dermatology website. So they absolutely can look ringworm-like. I don't think that Dr. Maurer was contradicting that, but I'll let you speak to it, Toby, because I've certainly seen some big annular lesions as well that turned out to be T-Mentag type 7.
Yeah. I mean, it's not as common to see that, those ring-like lesions. What people mostly see, or what people will report, is the more inflammatory lesion. So again, I would say if you're seeing inflammatory tinea, and that is, you may even have some scale, but there should be an inflammatory component when you're thinking about T-Mentag. So again, it's not that you necessarily will never see the scale, but there should be an inflammatory component, either presenting as a pustule or a red nodule, in addition to maybe some scale. But again, it's usually inflammatory tinea that we're seeing with T-Mentag.
I will
And
say,
again, I would
we're going to
say,
see, I think we're kind of seeing the tip of the iceberg of this. I think we're going to see more and more in
exactly.
different presentations.
I wanted to say that, Esther, that I think, we are starting to see different morphologic looks. That would not surprise me at all. Tinea is smart and changes evolutionarily. And so where in the past we may have seen more of the inflammatory type, I wouldn't be surprised that it eventually evolves into what we think of as usual tinea with scale and less inflammation. So I absolutely agree with that. Stay
And I
tuned.
Stay tuned. Yeah. And I would say we're starting to see even some that can almost look psoriasiform or like other things. So I think I would say with T-mentic type 7, I'm like, have that spidey sense out because it may not always look characteristic in one way or another. And I think just one last comment on that point around T-mentic type 7, keep in mind if you send off for tissue culture, they will not necessarily identify this correctly because the only way to identify this correctly is, particularly for you really have to do ITS genome sequencing, and your regular lab may not be aware of that. So if you send this off for culture, and it will actually potentially come back incorrectly as T-Mentag. So your lab will not tell you, I cannot test for this. Your lab will say, this is T-Mentag, and they'll actually identify it incorrectly. So just a small tip that you actually do have to send those for ITS sequencing if you are concerned. And the CDC is super helpful if anyone's not quite sure how to test on that. We're going to stay on the fungal theme for a little bit, Toby, because you've got a couple more questions on fungus. So I think one came up about asking about how worried are you about liver toxicity and how long you can use terbinafine. That's a quick one, and then I'll follow up after that with another one.
Okay. So terbinafine, we used to really be worried about liver toxicity and, oh my gosh, we were monitoring, et cetera, et cetera. The recommendation is that you do not have to monitor LFTs in persons who have not had a history of liver disease. It is extremely rare to have transaminase elevation in persons who don't have a previous history of liver disease. And interestingly, hepatitis from terbinafine can only happen within the first 3 weeks of taking the drug. So we always advise people if they're going to stay on terbinafine for longer than 3 weeks, that they should look for the signs of hepatitis, drug-induced hepatitis, which includes, let's say, jaundice and dark urine. And I always say, but it can only happen within the first 3 weeks. So if you don't have jaundice or dark urine in those first 3 weeks, you're good to go. You can take the terbinafine for whatever, 4 weeks, 12 weeks if necessary, without worrying about drug-induced hepatitis from terbinafine. Likewise, we don't monitor anymore. We don't get baseline LFTs unless we suspect that a patient has liver disease that we're worried about. And we don't get follow-up LFTs in 6 weeks, et cetera. We're just not going there. The rate of terbinafine toxicity to the liver is about, or I should say liver failure is about 1 in a million. So just to give you that statistic, it's exceedingly rare.
We're going to add another question, staying on the tinea theme for one more moment, and then we'll move on to some of the other questions. We have another question coming out of Ethiopia. If a patient shows no improvement after 3 weeks of terbinafine, are there any other clinical features that would prompt us to order fungal culture immediately rather than just extending treatment? And
Our
I'll make some
first
comment. Go ahead, Toby, and I might have some thoughts on this one too.
Yeah. No, now our first thought is to extend the time of treatment, longer duration, and then what we're second line is that we're adding or we're changing to itraconazole, and or adding itraconazole to griseofulvin, because these are showing less resistance. So one big question is always, hey, what about fluconazole? I will tell you that that's the greatest resistance around the world, mostly because fake fluconazole has been used, and by that I mean small amounts of fluconazole have been used throughout the world, and it has been very easily bought over the counter. And we have seen extreme resistance to fluconazole. So again, I would, number one, extend the duration of terbinafine knowing that terbinafine in parts of the world is resistant, like in Ethiopia, I would imagine that terbinafine is actually not working. Give it a go for a few more weeks. If you see nothing, switch to itraconazole, and then itraconazole plus griseofulvin is where we're going. Esther, I'd be interested in your thoughts.
Yeah, I guess my approach is slightly different, which is to say that I think that we are having so much drug-resistant tinea around that we have not recognized, and I have not seen it really fit such a perfect clinical pattern that my desire to test it is actually falls a little earlier. So I will say, if you look at our AAD template for how we approach these, is you give it a good 2 to 4 week try. If it's not improving in what should be appropriate therapy, it is reasonable to start down the pathway of testing. Doesn't mean you should stop treatment and wait for those test results. So what I would suggest is that you can be a yes and. So that I think it's very reasonable after 2 to 3 weeks, if you are on its appropriate treatment, for example, a healthy dose of oral terbinafine, and you're really seeing no response, it is very reasonable at that part to start thinking about testing. Um, and then continuing the treatment for a long duration. What we're seeing is that these resistant organisms just require an incredibly long duration of testing. I do want to just bring up, because I think the question was worded in such a way of when do we think about fungal culture? And I'll point out that fungal culture may not actually help you, unfortunately, because fungal culture will misidentify that as T-MANTAG, and fungal culture cannot, unfortunately, at this time, identify the whether it's resistant or not. So that does require ITS sequencing. So I just wanted to point that out, that I have that spidey sense of that concern that something different might be going on. I would pursue testing while continuing on therapy, and keep in mind that unless you're sending it for ITS sequencing, you are not going to necessarily get the correct answer of what your patient has and whether or not it's resistant. So that would just be my 2 cents to add on to Toby. And I think what's important to note is that Toby and I can have slightly also different thoughts on this, because we are a little bit in a guideline vacuum. There is no internationally accepted approach for exactly how to approach these patients. I do think this will be coming. The Indian Society has some guidelines. As I said, the American Academy of Dermatology has not put out a guideline. They put out kind of a rubric that you can follow in terms of testing, but there are no internationally accepted guidelines. So you'll notice that Toby and I don't necessarily have like the exact same approach, which I think is fine. That just shows that there's like a lot of also data and missing information out there. So it's a little bit of the art of medicine. I wanted to, there's a lot of questions on tinea, but I did want to also just turn back to one of our participants has asked about varicella, and they wrote chicken pox in adults with HIV. So I was wondering if you could just talk a little bit about that as well.
Sure. And I'm just going back to the tinea situation for
Yeah,
one
please.
more second, which is to say, it's always, it won't hurt to test if you have the test available. In the areas that we're speaking of that have the most prevalence of tinea, good luck. No testing available. Okay, so that's the reality. Don't know where the participant, whether or not the participant in Ethiopia has available testing, but it's harder than heck to do it most places, including the United States, I will just say. So you're right. Test when you can, but the reality is we ain't got the tests in most of the world. So we're sort of left with empiric treatment. To go back though, to chickenpox. So chickenpox is zoster, herpes zoster. Chickenpox is disseminated herpes zoster. It can disseminate de novo, or it can disseminate from an area of herpes zoster that we think of as shingles. So we have seen an area of shingles, and then if a very immunosuppressed host, that those shingles will then disseminate, and we call that disseminated zoster or chickenpox. So anyway, those are the sort of definitions of chickenpox. The thing to remember in HIV infected patients is that Herpes zoster can present as a monomorphic vesicular eruption, meaning that these lesions all look the same. That is not true in HIV uninfected patients. We often see multiple stages. We'll see a crust, then we'll see a pustule, then we'll see a true vesicle, all different stages. In HIV, it's monomorphic, which is kind of interesting and may give you a clue in some situations that you're dealing with HIV. And therefore, you want to think about testing for HIV.
Well, our time has flown by. Thank you so much, Dr. Maurer, for those insights, and always such a fascinating and challenging area. We really appreciate, I apologize for anyone whose questions that we didn't get to. It was a really healthy discussion there in the Q&A, so I apologize that we weren't able to get to everyone's questions. But I know Dr. Maurer is also someone who's very good at answering questions offline as well. So as I volunteer you,
Happy
Toby,
to do that.
as I volunteer you. But we really appreciate all of you joining us today. And any more information on how to claim your CME or your pharmacy or nursing credits or your certificate of participation will be emailed today at 5 p.m. Pacific time, the next day after the webinar. And just to remind you again that Toby has an excellent webinar last year on KS, in particular on the IAS-UAS on demand. So please do take a look at that. She has provided a lot of information I think will be helpful. We kind of touched a little bit today on some topics on KS, but very briefly. So I definitely encourage you to take a look back. Also a reminder, Going Antiviral, love the name, is the IAS-USA podcast. And the latest episode is on tracking Ebola, the outbreak status. And to remind you that there is lots of wonderful educational content on the IAS YouTube channel, which you can follow here. And our next upcoming webinar will be the review of data presented at the 2026 International AIDS Conference, and that is coming up on August 11th. And there's the registration link. And we also have the IAS-USA Dialogue Series, Emerging Infections and Health Threats, coming up on September 3rd, and registration is open now. And as well as the IAS-USA Annual Update on HIV Management course that's happening in Chicago on October 15th. As well as a virtual course on Beyond Antiretroviral Therapy, Hot Topics in HIV Primary Care in November. And as well as Emerging Challenges in HIV Medicine, that's coming up on December 1st. And a reminder that the on-demand recording for this session will be available within 24 hours after the live broadcast under the IASUSA.org website under Activities, Webinars, and then there's an archived CME webinar page. With that, I would like to say a huge thank you on behalf of both Dr. Maurer and myself. It's been a real pleasure to be with you today, and thank you for inviting two dermatologists into your homes and your offices. We really appreciate the opportunity to share our perspective on HIV and skin health with all of you. Thank you so much.
Thank you, everyone. Thanks, Esther. Thanks, IAS USA. Thank you.